Good morning, everybody. Welcome to Friday Chalk Talk. I'm Leanne Lau. I'm one of the moderators. I am delighted this morning to introduce Gretchen Schwartzy. Gretchen is from Madison. She's at UW-Madison. I know you've seen her little bio in Marty's um, weekly update. She's a vascular surgeon, which anybody who knows what vascular surgeons actually do knows that it's a lot of palliative care. It's the surgical version of it for the most part, unless you're operating on young, healthy trauma patients, I think is the big exception there. But so she has dedicated a good portion of her research career on clinician patient communication. And as we were just talking about, this has been an evolving process, which I'm just so excited and delighted to see what the next steps are to all of that. But her fun fact is that she does Peloton. I love that it's Hey Gretch because I'm just imagining like the Peloton instructors like shouting out. I've never done Peloton, but I've seen things enough where I figure they sort of try to encourage different participants. So I really like that. That's what I'm imagining now. So with that in mind, we're going to be talking about feeding tubes and kind of how clinical momentum plays into decision making, specifically again in the context of feeding tubes with advanced dementia. But I think Gretchen's insights are widely applicable. So with that in mind, Gretchen, I'm going to let you roll.
Great. Thanks, Leanne. It's clear you don't do Peloton because you would know that you'd have to be at the very top of the leaderboard for the Peloton instructor to call you out. So there's no chance I will ever be called out because I am not anywhere close to the top of the leaderboard, but that's okay. All right. I'll have you advance the slide forward here, Leanne. And the first slide I have after my title is really just to thank the funders, people who have been really for years funding my work. Whoa. Wow, Leanne, this is impressive. I just want to be really clear that Leanne is making the slides move and it's not me. Okay, so I do have some funding from the NIH presently, and also the Josiah Macy Foundation. And none of the work that I do is obviously going to be profitable for any sort of commercial reason, but I am awfully grateful for the NIH for funding this. They none of these grants fund the work I'm going to tell you about today, but the work I'm going to tell you about today was funded by an R21 through the Institute for Aging. Go ahead to the next slide, please. So I don't know how many of you remember the support study, and there are two support studies, but this is the support study that was done by Joanne Lynn and a bunch of really amazing geriatricians back in the late 90s. And they had this idea that if we could just facilitate communication between patients and families and the clinicians who are taking care of their loved one, so that patients and families' ideas about how to take care of their loved one got translated to the clinical team, and the clinical team's ideas about prognosis got translated to the families, then we would have much better end of life care. And they basically, oh, backwards, please. They basically randomized 5,000 people to this intervention. Backwards, one more. They randomized 5,000 people to this intervention where a group of nurses facilitated all of this communication. And these patients were very sick. They were dying in the ICU. And what they found at the end of the study, and it was very upsetting at the time, was that this communication intervention had no effect. It didn't change end of life care or time in the ICU or any of the treatments that people had by facilitating communication. And Joanne Lynn, who is one of my heroes, was sort of beaten up in the literature. There were like tons of reports saying like, how could they have done this? And there's something wrong, and their methodology was bad. They had like list was very, very long. And she wrote this brilliant response. It's still one of my favorite papers ever in JAGS in 2000, taking everybody's concern bit by bit by bit. But mostly what she came up with was this idea that communication, while it seems like it's the problem, is actually too is not a big enough intervention to overcome the underlying practice patterns and the way we take care of people. And really, that the course of care, the care that people get at the end of life or while they're very, very sick, has a lot to do with how the system is set up and how we typically take care of people. And that without thinking about the system as a whole and professional routines, all the best communication interventions in the world are not going to make a difference here. And I have to say that we have found this as well. And I know this sounds horrifying because I study communication interventions, but we have also seen this idea that it's the patterns of care and the system itself that are determining the kind of care people receive. Go ahead to the next slide there, Liam. And so we first heard this from our surgeons. We were talking to them about a communication intervention. And we said, do you think this frail elderly woman should have her aneurysm repaired? And the surgeons were like, she should definitely not have surgery. This is a really bad idea. And then they'd sit there for a few minutes and they'd say, but she's going to have surgery. And they came up with a whole bunch of reasons for why she was going to have surgery. And basically, what they said is like the system is programmed to make this operation happen. The family assumes that surgery is going to make them better. The person who consulted you expects you to operate. Somebody has called the operating room and they're already ready to take you, so that the pace of care and the expectations around how the care would be provided were sort of moving the care forward without the surgeon's ability to even slow that care down. And so we came up with a model of what we call clinical momentum, which is a way to describe these forces, which we call latent forces, which means they're hard to see, that move the care forward. And this is sort of the first paper that we publish of what this model is. And we recognize that there are a bunch of elements in the system that are moving things. And so one of the biggest elements that we see in our data is something that I would call the fix-it model, which is that we get really focused on, say, the aneurysm, right? And so we're asked to fix the aneurysm. And of course, surgery is a thing that fixes the aneurysm. And we think of people as like they're disarticulated parts. And when we're talking about whether we should do something for them, we just talk about that thing as opposed to the patient as a whole, which I don't really have to tell a bunch of palliative care clinicians that this is a problem. You already know that this is a problem, but the rest of the system works this way. Also, this idea of recognition prime decision making, which is sort of this idea that when people are sick, we try to rescue them and we do it very quickly. So if we see somebody's SATs going down, we quickly apply oxygen, not by thinking through what their problem is, but just by saying, oh, when their SATs go down, this is what we do. Over time, all of these treatments that we do build up, and they have things called the cascade effect, which means that sort of one treatment then encourages another treatment to happen and encourages another treatment to happen. And then there's this economic behavioral economics force called sunk cost effects, which is like we have done so much already, we might as well continue. And so this is sort of what happens, that the patterns of usual care move forward without us, and the clinical momentum, the practice norms push it forward. Next slide, please. So we wanted to study this, and the reason we studied it in patients with dementia and who got a feeding tube is that it's hard to make when you're thinking about sort of unwanted care at the end of life, that's a judgment value. And we wanted to find a space where there was more guideline determination around whether this was good care or not good care. And I recognize that even though there are guidelines that say patients with advanced dementia shouldn't have a feeding tube, there may be some exceptions to that rule. So even having a guideline doesn't help you sort of say for sure this was not good treatment. But we sampled patients in our hospital, and then we interviewed the patients who got a feeding tube with their advanced dementia, and then we interviewed the clinicians taking care of them, and we interviewed their family members. And what we were looking for were these systemic forces that contributed to the care that they got. And you can see these quotes that come. These are the quotes that I put up from the nurses and the dietitians, that their jobs are really this sort of fix-it job and to stabilize the problem. That's like recognition prime decision making. And that when they think about the care they're providing, that safety is a very high factor in part of what their job is. and that everybody on the team has a different role. And so we follow the people's who sort of have a lead in that role without reconnecting the whole patient back together and sort of collaborating as a team to think through, like, what does this mean for the whole patient? Next slide, please. So so this is a composite of all the patients in our initial qualitative study. It's not one patient, but you can imagine sort of how the clinical momentum goes down. The patient gets admitted, they have altered mental status, they get medicated, they see the nurse sees the patient's choking on pills, they make the patient NPO. Well, now the patient's NPO, but we still need to get medicines in them. So we put the Daboff tube in, and then we get a swallowing study. And not surprisingly, the swallowing study shows that there's some aspiration. So now we have a fix-it problem because we're going to fix the problem by, leaving the tube in and feeding them through the tube and not letting them eat. And then, oh, the patient's other medical problems seem to have stabilized, but we want to send them home, or we want to send them to a nursing facility, but you can't go to a nursing facility with a Daboff tube. You have to have a permanent tube. So all of these sort of pieces that none of us would think twice about if it just sort of happened to a different patient add up together. And maybe people didn't even think twice about it for this patient, but before you know it, we're at the end of the patient's admission and the patient needs a discharge disposition. They have a Daboff in, and we're talking about, should we take the Daboff out, even though we said that they needed it? Or should we put a permanent feeding tube in and send them to the nursing home? And this is sort of where palliative care gets called. And when we interviewed the palliative care clinicians for this study, they were like, it is very hard to show up at the end here and put the brakes on all of this momentum because the family has already been told that this is something the patient needed, right? And it, much like my surgeons who said, I can't not operate on this patient, it is very hard to undo the momentum as it moves forward like this. So for the study that we're talking about today, next slide, we had these ideas around the concepts in clinical momentum, which are in the gray boxes here. But then we found events that happened in accordance with these concepts. And we thought if we could do a retrospective chart review and see how many people had these events happen to them, it might allow us to understand in a larger way rather than with a small qualitative study, but maybe we could do it sort of through big electronic health record investigations. It might allow us to understand sort of how prevalent the sort of notions around clinical momentum are. And so you can see that there are these little events that happen that are associated with our constructs. And so we did a retrospective chart review, and we did a case control retrospective review, and we enrolled about 76 patients. Next slide. And we described all of these events that we had seen in our qualitative study. And I can see one of our statisticians, Lily Stalter, is on. And Lily is not only brilliant in her ability to just do really great statistical work, but also to find amazing graphic representation of what we found. And so we found this chart called an upset plot, which is the chart that you can see here on the left side. And the patients who got a feeding tube are in the yellow, and the patients who didn't get a feeding tube are in the greenish color here. And you can see that the patients who got a feeding tube actually had a lot more of these events that we had seen in our qualitative study. And the patients who didn't get a feeding tube had fewer of those events, or fewer of those events stuck together. I want to call your attention to the figure in the right upper corner here. And it also shows here that the patients who got the feeding tube were just in the hospital quite a bit longer. And so this feels a little bit like a study of the obvious, but the longer you're in the hospital, the more things are going to happen to you. And you might imagine that the more things that are going to happen to you, the more things are going to build up. And so it's a little awkward in part because you sort of think, well, maybe these patients were sicker, maybe these patients, just the exposure period of being in the exposure period of time in the hospital contributed to all of these things. And I think the short answer is yes. And they still, at the end of the day, ended up getting care that we might say is guideline discordant. So I recognize that I've sort of taken quite a bit of time here to talk about this, and I'd love to discuss it a little bit more. I wanted to show two other episodes of clinical momentum just to sort of get our head around this phenomenon. So this is my dear friend Susan Wong, who did a beautiful study in the VA about patients who were not particularly interested in having dialysis as an outpatient. And then they came into the hospital, and all of a sudden, the sort of run towards dialysis really picked up. And it was sort of this idea that they got admitted to the hospital, and now it was an opportunity to move forward with dialysis. Next slide, please. Um, and then this is another colleague of mine, Renee Boss, who is a pediatric intensivist. And I really love the way Renee sort of did this notion of clinical momentum in the PICU, which is that you can see in the dotted line, this is sort of how parents think about their children in the PICU. And the solid line is how the clinicians talked about the child in the PICU. And so when the child was admitted over at the beginning of like the zero space on the x-axis, the clinicians would talk about the child and talk about the child's creatinine and their saturation and their PEEP and their urine output and their anemia. And the family members would talk about their child as a whole child and their hopes and dreams for the child. And over time, as the child got sicker, the clinicians would start talking more and more about the child as a whole child, and the family would start talking about, well, what about the PEEP? What about the creatinine? And I think that this is a really important point that Renee came up with, which is that while it feels like it's coming from patients and families, I actually don't think it comes from patients and families. I think we teach them this. And so that when we start to disarticulate people into their component parts and start talking about fixing things without thinking of the patient as a whole, they learn that. And then they say, well, why can't we fix this? Right. And then it really changes the kinds of conversations we're having. So I'm just going to put up the last slide here because I recognize that this is a short talk and it may be helpful to have additional resources. My website is patientpreferences.org, and we have a bunch of our movies on communication, as well as more detail on where some of these papers are published. I just want to thank my amazing research team. You just can't do all this work without a tremendous group of people. And it's really hard to be from Madison and not show a picture of Bucky Badger at the end of your talk. And then I'm just going to put up the last slide because I think it may be something to think about as we're having a discussion here. Was that
Well,
helpful? Yeah.
yeah, Gretchen, thank you so much. I'm looking at the chat here, and Elizabeth said that that graphic was great. I think that was with that last one, and I agree. I'm just going to quick click back to it. That
Yeah.
what I really love there is how well it visual you can visualize that actual problem focused versus patient focused discrepancy. So I think Marty said he had a comment. I'm not seeing anything else in the chat. So Marty, I'm going to let you go first.
Sure, I'd love to. Thank you. And I want to appeal to the ethics background you
Mhm.
mentioned in your bio. So I wanted to share a comment of what I was chewing on when I was reading your paper and just whatever reflection you have on it. So I think it is interesting that peg tubes and dementia are really a great example of how medicine is this three-legged stool, where you have the practice of science, you have the practice of humanity, and then sometimes what is forgotten is it's also the practice of morality, right? And clinicians are moral agents. And so even though we put autonomy up on this super high pedestal when there are conflicts involving, values that are subjective, cases like this where there's real harm that could be done, I think that shifts that autonomy to thinking about what is the objective good of medicine, what is the moral good of medicine. And I think we in palliative care are poised to be in a position where we can help remind the team of some of those things to counteract some of these clinical momentums.
Yeah, I love that strategy, Marty. And I think that, I think you're spot on about what the issue is. Like we have spent so much time trying to figure out how to make something better or how to do new treatments or solve some certain problem. And we have spent very little time figuring out whether we should use these treatments in a whole range of settings. And I think that all of us can think of different things that we've seen change during our time as a clinician. Like, I mean, I can now put a stent in a ruptured aneurysm, which when I was a resident wasn't even a possibility. We put so many people on ECMO. Like the technologic advances are extraordinary. And somehow this sort of idea of when and how to apply these technologic advances just has not kept up with the technology itself. And I do worry that some of the ideas around how to support patients and families, I think palliative care has done an extraordinary job in working through this, but those ideas haven't spread as much as we would like through people who aren't in specialty palliative care. And it seems to me that there are some real sort of traps around things like consent and shared decision making, that if we could do those things better, we could back off some of this as well. I think at the end of the day, even when we communicate well, the entire system is incentivized to intervene. And I think that that's okay. It works well for a large majority of patients, but it causes real harms for the patients who don't fit that model well. And what we haven't done is sort of figured out like, A, who doesn't fit the model well, and B, if you don't fit the model well, how can we best take care of you? I think some of that's the incentive, but I think other piece of it is sort of lack of imagination that other people might not fit this model so well.
Thank you.
Thank you, Gretchen. So the comments are coming in fast.
Yeah.
So which is great. So Rachel's asking, and this is a great follow-up to the comments you were just making. Do you know of, or do you have any other recommended training
Mm.
to help other healthcare teams open their minds to that whole person approach? Is there anything you've seen that you think would be helpful to recommend?
Yeah, I love Rachel's question, and I probably could talk for hours about this. And I just want to be clear, like I'm kind of a one-trick pony, and this is not one of my tricks, the clinical momentum piece. I'm really in this communication space for specialists and really for non-palliative care specialists, right? For surgeons and nephrologists and other people. And so my short answer to that is that we do have a best case, worst case ICU intervention that we're studying in the trauma situation right now, which I do think helps the team connect the dots around having this sort of systems review of the patient where we sort of say, you know, this is neuro, this is cardiac, this is pulmonary, and then at the end say, this is what I'm hoping for if things go well, and then tell a prognostic story about what it would look like if we moved forward with this direction of care. And so, in my mind, that is a way to get teams to start thinking through like, what are we trying to accomplish here? And what would that look like for the patient and family so we can make sure it's valuable to them? I do not think it is the be all end all answer, but I think that there are interventions that we could use that would allow people to both do their job where they have to identify things like the low hematocrit or the dragging urine, and then put it back together and say, well, what does this mean for the whole patient? But Rachel, I think you're spot on, is that the ability to sort of connect those dots on a daily basis and sort of cognitively say, okay, this is where we're going would make a big difference.
There's a couple comments in here about the idea that a feeding tube is a response to aspiration that's expected to eliminate it, and then the idea of the three pillars of aspiration pneumonia are really helpful.
Yeah.
I just want to make a comment that I noted specifically when I was reading your study about this, Gretchen, was that some of the even nursing staff was one specifically that I remember that said it's going to prevent aspiration, right? And so that's some of these things I do agree are on some level education issues for what needs to happen. Since that wasn't specifically a question, I'm gonna move on to another question from Steve Rommelfanger that he's asking, do you favor, in the context of clinical momentum, do you favor palliative care triggers to be implemented to improve care in dementia and PEG tube type scenarios?
Yeah, I mean, I love this question, and I wasn't able to sort of describe all the things that we did during our study, but I will tell you that one of the things we did in this study is to make it multi-site, and we have a community hospital where we tried to enroll patients, and we never once found a patient who had advanced dementia and a feeding tube. And so we had to like sort of walk it back and figure out like we had to like totally change our whole study there. And so we interviewed a whole bunch of clinicians and said, like, well, why doesn't this happen here? Because it happens over at our hospital all the time. And they basically said, sort of in the early 2000s, they had a policy that if you were going to put a feeding tube in a patient with advanced dementia, you had to call an ethics consult. That was the policy. And they didn't really do anything more other than to say, this is the policy. But what happened is over time, culturally, and it was actually really, really hard to study this in a systematic way because we were trying to like interview people from a long time ago who had enough institutional memory to be able to tell us what happened. But what we gleaned from them is that over time, because they had this rule, the culture changed. And when it came to thinking about like what to do when someone was aspirating or what to do when they weren't taking in enough nutrition, they just never put in a dob off and they didn't call an ethics consult because they just had this idea that like we don't do that here. Like it was just their culture to not use feeding tubes in patients with advanced dementia. And it was like very unsatisfying as a researcher to try and explain what happened. And I feel more confident in explaining the result of what happened, which is like literally they don't do it there. But how that came about, that's the best story I could come up with. So I think Steve is right. Like the idea of triggers or the idea of something that happens on earlier in the course of care that would slow the momentum or disrupt it would make a difference.
That's so great. I'm not seeing any other questions come up. So Gretchen, I want to ask one, mostly because I want to give you an opportunity to mention this, because when I asked you when we met beforehand what you thought was the most interesting about all of this, you mentioned the fix it mentality, and then you mentioned the big idea of always relating the four goals to any surgical procedure. And so I really, that's one of the things that I've loved talking with you about over the years in terms of surgery discussions. So I wanted to give you a chance to bring those up.
Yeah, I mean, I do think that like in my mind, the fix it component of clinical momentum is the most pervasive and probably the most dangerous. And I think the challenge is it comes out of this really authentic desire on clinicians' part to explain why we're doing things, right? If I have an aneurysm and I can fix it, why wouldn't I do it? And we use a lot of language in this way, not just as surgeons, but as in many places. You have a blockage, we're going to go around it. You have a cancer, we're going to take it out. And I think like this resonates in the feeding tube space, right? It's going to fix the aspiration. And you can see why the nurses sort of think it might fix the aspiration because it just seems so very mechanical. But like it belies the sort of aspect of what it means to be a human. We're not cars and we can't be fixed in that way. And so the model actually doesn't work the way we would actually want it to. And so what we've been trying to do with surgeons is to sort of have them step back from that model and say, if we were going to do this operation, what will it accomplish for this patient? And what I ask the surgeons to do is to say it has to be one of four things, because surgery can only do four things, which is to help you live longer, to help you feel better, to help preserve function or prevent a disability, or to make a diagnosis. That's it. So when you talk to patients and families, I don't want you to tell them that this is going to take the cancer out or fix their aneurysm or bypass the blockage. I want you to talk to them about what surgery can accomplish for their life that is plausible for them, and then figure out if that thing is valuable to the patient and family. Because I worry that so much of healthcare gets driven around this, like, you have this, we're going to fix it. And we don't connect the dots for patients and families to say what it will do for their life. And I worry sometimes like we don't connect it for ourselves. Like I'll be in the operating room with a trainee and say, like, why are we doing this operation? And they'll be like, the ABI is 0.3. And I'll say, well, why are we doing this operation? They'll say, the patient has peripheral vascular disease. And I have to ask this question like 5 or 6 times before we get to get the patient out of rest pain so that they can sleep at nighttime. And I worry that without making these connections, we sort of move forward in this space that drives care, which is to sort of identify and then fix, instead of thinking in a more broader way of like, what is this going to accomplish for this patient? And is that actually valuable to them?
Thank you, Gretchen. I always love hearing you say those things. Elizabeth B. made one more comment here that it's back to the age-old but necessary debate of not can we, but should we.
Love it.
And I think that's a really succinct summary of what you said. I'll say that after hearing you talk about this quite some time ago, that absolutely changed the way I approached teaching residents about and actually not just the surgical residents, teaching anytime I'd talk about palliative care lessons, I would include this idea um, for all of my discussions. So I'm not seeing anything else coming up in the chat, and I think we're at 10:10. Marty, do you have anything else? No? Okay. Gretchen, thank you so much for talking with us. This is such a great talk this morning. And with that, I hope everybody has a really terrific weekend. And I think, Marty, is there a session next week, or is next week a week off? I can't
Oh,
remember.
there is, and it's
It's
Okay.
the perfect part two because we're going to talk a
Oh
bit
yeah.
more about the ethics of this. So.
Awesome.
Awesome. So we'll see everybody next week.
Thanks so
Thank
much for
you.
having me.
Thanks, Gretchen.
Bye.
Bye-bye.